Hi everyone, it's Dan Kamenstein. Welcome to week 13 and our facilitator case review. So I thought I'd start out by going through some of our QACs, so our more specific learning objectives for this case. And then we'll jump into the faculty guide and talk briefly about the article that we're going to go through this week. Before we get started, just to orient us, I wanted to show you what this week of week 13 is going to look like. So this is shoulder week, so the students are going to be mostly focusing on the anatomy, structure, and function of the shoulder, pectoral region, and brachial plexus. The brachial plexus is probably one of the more complicated anatomical structures that they've encountered so far. We're not going to spend a ton of time delving into that in the case, but students should certainly touch on that. So they'll get an orientation to that. They're going to have 2 dissection labs around the shoulder, brachial plexus during the week. And then they get quite a bit on myopathies. They're going to get an introduction to musculoskeletal disorders from Dr. Moore. So a lot of the things that they should have on their differential diagnosis for this case should be touched on during this week. They are then going to get a lecture also on some shoulder imaging. So that's going to touch on X-ray and MRI. During PCL, they're actually going to have some information about doing a comprehensive shoulder examination. So they'll actually be able to talk through how you do a full shoulder examination. And then they actually are going to have some time in the ultrasound lab over the next couple weeks doing an actual shoulder ultrasound as well. So a lot that's going to tie into this case. And that's basically orientation of kind of what week 13 is going to look like. Now, most of the students will have PCL during this week, and so they'll do the comprehensive shoulder examination. The ultrasound will actually be spread out over several weeks, so not all of the students will have done the ultrasound portion of the PCL component during this week. So let's jump into the learning objectives or the QACs for this module, for this case. So some pretty generic stuff. So we, again, want them to modify a differential diagnosis for acute shoulder pain, kind of come up with a differential diagnosis. The case this week talks about a patient who uses anabolic steroids. So it's a chance for them to think about how anabolic steroids work, and not in extreme detail, but a little bit into kind of how they affect muscle growth. Again, a lot of the work they're going to be talking about myopathy. They're going to be talking a little bit about muscle structure and function, so they can think about how kind of steroids work at the cellular level and build off some of the information that they gained during the foundations module. We also want them to really interact with a lot of the psychosocial components of this case. So this is a patient who has their career challenged by this injury. And what are some of the diagnostic and treatment decisions that are limited or challenged by a patient whose livelihood is actually threatened by their injury or disease process? Of course, we really want them to think about the anatomical structure and function of the shoulder, paying particular attention to the rotator cuff, which is often tested, but also all of the other underlying anatomy, thinking about the brachial plexus as well, looking at, again, how we image the shoulder, what the common things we use to image the shoulder, the benefits and the downsides of those. The shoulder and the neck have very complex neurovascular supply. And so that is another thing we want them to think about as they're dissecting into the axilla, is thinking about what nerves, arteries, veins run through the shoulder. How do they then supply the arm and forearm? In the coming weeks, they're going to go through arm, forearm, but we just want them to get a sense that most of those important structures that get to the hand have to pass through the axilla first, and thinking about that. Our patient also is going to have some issues with advanced imaging, and so thinking about the costs versus benefits of advanced imaging tests, looking at multimodal pain control and thinking through how we approach and treat acute pain, chronic pain, certainly with the opioid epidemic. A lot of emphasis has been focused on how physicians approach patients with acute pain, how much opioids they use, how many other drugs, and what other ways to control pain are out there. So something the students should start to think about during this case as well. We also have built in a little bit of the medical error and task switching challenges that occur during a busy clinic, so they should think about that as well. And then because in PCL, we're going to be covering the shoulder exam in more detail, we want them to think about the ideal shoulder test and how that helps with creating a differential diagnosis, guiding your diagnostic imaging, guiding your treatment plan. And then finally, we have a patient who uses anabolic steroids, partially for his career, but also based on some body image challenges that he has. And we want them to think about kind of the body image concerns increasingly for both men and women, and how that has presented particular challenges in regards to the way that people approach their diet, the way they use supplements, and some of the health concerns that come up with that. So that's really our focus for the week. And with that, let's jump into the case a little bit, and we'll see how these things play out a little bit as the case develops. So we have Mr. Brokestone. He's a 36-year-old right-hand dominant professional weightlifter. So age, hand dominance, and vocation are pretty important when you're approaching someone with an extremity injury. That may determine how you approach them and how you treat them depending on what their vocation is. You may approach a major league pitcher who has a shoulder injury a little bit different than a emergency medicine physician who has a shoulder injury, purely based on the career they have and kind of the long-term implications of minor shoulder injuries, minor musculoskeletal injuries for professional athletes compared to others. So in this case, we have a 36-year-old male who is a professional weightlifter and does that by basically producing videos on YouTube. So this shoulder injury is a potentially career-threatening or career-ending injury for him. And so that may have specific implications about how we approach him and how we treat him. So the initial part of this case goes through his description of the injury, talks a little bit about a videotape of him, and the students actually will get a chance to see that during the ultrasound portion. So we don't have the videotape, but they actually will watch that during the ultrasound portion. It's a little bit of a fun takeoff of some of the YouTube weightlifting videos that you might see. He has some underlying medical problems, so he's young, and the students should think about a little bit about, okay, why is he already hypertensive and has gout at such a young age? And that may be a genetic component to that. It also might be some of his performance-enhancing drug use has actually increased his risk of hypertension at a young age. So he is pretty young for those, but we wanted the students to kind of think about a patient who has more than one problem going on. Again, he is a self-employed. He runs his own YouTube channel, and that will play into the approach as well. He has 2 children. He is currently separated from his partner, but is also sexually active with multiple partners. So that certainly does increase his risk of other diseases and high-risk behavior as well. So he does use anabolic steroids and started using them initially as a high school athlete to get ahead and has continued to use them. The initial review of systems there really isn't very much beyond just his complaints and the musculoskeletal component, which is described in the HPI. So after this initial presentation, students should start to think through a problem list, kind of what are some of the things we should worry about. So obviously the patient's initial shoulder injury, the numbness he's describing, and this is to get students to think beyond just the musculoskeletal component and think about all the neurovascular components of this. This would not be the common injury for a typical nerve injury in the brachial plexus, but we want them thinking broad initially and then narrowing down their differential diagnosis. Obviously, his use of anabolic steroids, his unprotected sex also are concerning. So one thing that we don't touch on too much in the case, but certainly could be brought up, is gonococcal arthritis can be caused by gonorrhea that's acquired by having unprotected sex with multiple partners. So an arthritis picture would be pretty uncommon for the way he's presenting, but should be in the differential, especially because he has gout as well. So this is just one more layer of things that students might add on to that. We want them then to create a differential diagnosis. We are still encouraging that vitamin A, B, C, D, E mnemonic to go through a complete differential diagnosis, and this is where they should be able to touch on lots of different components of this. Even if they're not the most likely, they can kind of hit on several different systems as possibly contributing to this. I also provided here a little bit of a flow diagram to think about once you get down to the actual shoulder itself and you think about the structure and function of the shoulder, breaking the shoulder up into components based on the anatomy may help you also organize a differential diagnosis. So this isn't the full vitamin A, B, C, D, E mnemonic, but this is another way of once you get to the actual anatomy of the shoulder, the anatomy itself can help you break this down. And so I kind of gave an example of how you'd use the joint space, the bones, the muscles, the ligaments, the tendons, nerves, vasculature, referred pain from other things to kind of think through, okay, well, where would some of the common and maybe not so common shoulder injuries fall in that? So again, another way just for students to kind of break that up. You don't have to show them this specifically, but you might encourage them to think about how does the anatomy you learned this week or learning about this week, how would you break down a differential diagnosis just based on the anatomy? And that's getting the students to connect this presentation with some of the anatomical ways that the shoulder is and the axilla are broken down, and helping them think through, wow, the anatomy actually helps me think about what types of injuries might happen and what might be less likely. We also want them spending some time thinking about the structure and function of the shoulder. Now, they're going to get quite a bit of this during their lecture time, so they don't have to spend tons of time thinking about this as a presentation on itself, but we want them thinking about how does the structure and function help you with your initial diagnosis and treatment. So the patient does have some neurologic complaints as well. And this is, again, just to get the students to think about the brachial plexus. What is it? How could it be injured? This wouldn't be the most common way to injure the brachial plexus, but we do want them at least engaging with that concept of the brachial plexus because, as we said before, that's probably the one of the more complicated anatomical structures they've come upon so far in their dissections. We talk a little bit about the medications he's on. So he is on allopurinol. This is just another chance for the students to kind of think through the pharmaceutical side of this. And they already had pharmacokinetics and pharmacodynamics initially. And they're going to have a lot more information about gout moving forward during this module. So it's a good chance for them to think about what is gout and how might you treat gout as well. Obviously, one of our biggest concerns is that Mr. Brokestone is self-administering anabolic steroids, and he's using a steroid cocktail. In a lot of cases, the concern would be for reusing needles. So if he's injecting the steroids, which is commonly the way that the anabolic steroids are administered, is injection. So he might be reusing needles. That certainly could be a concern. If he's sharing needles with someone else, that's obviously a concern. And then steroid cocktails are often beyond just a single anabolic steroid. Oftentimes, patients will use other drugs to help counteract the side effects. So he might be using a diuretic to counteract some of the fluid gains and weight gains that occur with use of anabolic steroids. He might be using some other supplemental medications to, again, counteract some of those side effects. So the students should kind of think about, is it just the steroids that are a problem, or what other drugs might he be using? And they can just search through kind of what is an anabolic steroid cocktail look like. There's a lot of descriptions of that in the literature, and just thinking about kind of generally not just the abuse of the steroids, but kind of a kind of polypharmacy approach to these types of patients. And the clinical application of that is oftentimes, as a physician, they will encounter patients who are starting to use drugs that either they have left over or someone else gave them, and just thinking through that whole process of what else could a patient be using when they present to me. So now we have the initial presentation. He is a little bit hypertensive, and we have a limited shoulder examination here, mostly because the patient really won't range his shoulder very much. And that's on purpose. We want the students to initially think through what are the challenges of someone who presents with acute extremity pain and has limitations to their range of motion. How do you actually evaluate that? What should you do? How hard should you push them? Should you make them range their shoulder even for their extreme pain? It's also a chance for them to then go into PCL and actually walk through a detailed shoulder exam. So this is a pretty limited shoulder exam. By the end of this week, they should have a better sense of how you would do a detailed shoulder exam. Based on that history, they still should be able to narrow the differential initially and think about some pain control. So the patient is in extreme pain, and they should think about, well, how do we want to control his pain? Should we give him something very strong, like an opioid? Again, some of the challenges of opioid, especially amongst the opioid epidemic. If he's already been using some over-the-counter medications, what are the other potential options there? And he has elevated blood pressure, and so he has a history of hypertension. He comes in hypertensive. Is this something we should worry about? Is it something that we should not worry about? And it allows students just to start thinking about this idea of hypertension as well. And we've talked about this before, but certainly his anabolic steroid use and some of the concerns about that. There is some evidence that probably anabolic steroid use does increase the risk of musculoskeletal injuries for lots of reasons, and there is a reference there. But students should be able to look up and kind of say what risks is he under just by using the anabolic steroids from the perspective of actually increasing his risk of injuries. We also wanted them to talk and think a little bit about generally how students get involved in using performance-enhancing drugs and why they might do it, and some of the body image reasons that both male and females end up using pharmaceuticals to enhance their body image, and some of the challenges of that, some of the health risks of that. I will actually jump into the article now. So the article for this week is actually a discussion on the legal performance enhancing substances. So these are not the illegal ones like anabolic steroids, but some of the legal performance enhancing substances that can be used, and then some of the ensuing substance problems that occur among young athletes. And so this is another just kind of chance for the students to interact with the challenges of over-the-counter medications that may be available, illicit substances that might be available, and the ongoing long-term health consequences of that. Part 2 will be the IPASS. The students should present their learning summaries. They do not have the specific QACs, so there should be a lot in that first part of the case. There should be tons that they should talk about. And I just walked through a bunch of the things that they could spend time on that would be hard to cover during the course of the lecture, but are really valuable tools. So when do we worry about hypertension in an acute office visit would be a great thing to talk about during a learning summary. They're not going to talk a bunch about hypertension during this week. The structure and function of the shoulder probably is less valuable as a presentation and learning summary because they're going to get a lot on the structure and function of the shoulder in their lecture time. So there should be some good learning summaries here, and then we get to part 2 of the case. So we are in the family medicine clinic, and Mr. Brokestone's physician arrives early. So this is kind of a preview of this, and that physician gets a note, which are very common in the physician portal. So this is the way that patients will often message physicians now and says, I'm feeling worse, I can't get any sleep, can you give me something else? And this physician is then overwhelmed with a bunch of phone messages and says that one of those messages is also from Mr. Brokestone, who's having increasing pain and inability to sleep. So his x-ray is pulled up, and this is what we find. Now, the astute students will make some notes about this, and this is done on purpose. But one problem, first of all, is that this is the left shoulder. Now, if we remember back to the initial presentation, this was Mr. Brookstone had an injury to his right shoulder. This is a pretty dramatic humerus fracture. And if you notice up here, this is obviously fake, so this is not a real patient's information, but here we have the name of the patient, we have the date of the study, and we also have an MRI in here. Now we notice that this patient is not Mr. Brokestone. And so what happened is that the physician in their haste to try to multitask pulled up the wrong x-ray. So they pulled up a shoulder x-ray, and if they don't catch that, that would be pretty concerning because this is a pretty significant injury for the mechanism of injury, at least that the patient initially described. So they can walk through this. They should certainly be able to identify the fracture there, so they can talk about that. But the main thing we want them to walk away with is we want them to identify that this is the incorrect image. If they don't identify that it's the incorrect image, what we would encourage you to do is do not tell them that it's the incorrect image. Walk through, what's concerning about the x-ray, what might be concerning about this type of fracture, and what other images they could obtain. So there certainly could be a robust discussion about what types of shoulder x-ray and imaging is best, and why an initial shoulder x-ray might be valuable in these cases, and what other tests might be done in this situation. So we have a lot on shoulder radiography, CT of the shoulder, MRI of the shoulder, ultrasound of the shoulder. This is, again, in the faculty guide. This is purely for you to review if you don't have much background in shoulder imaging. The students are going to get an entire lecture on this, so do not feel that you have to cover all this, but if they start wanting to create some learning summaries around this, we provided this here so you have some brief summaries. I do not expect the students to go through all of those aspects in just this part of the case, but we wanted to provide it for the faculty guide because they may bring up some questions about different imaging studies that might be available. So they might suggest, well, maybe we want to do an MRI or CT now, and it would be helpful for you as a facilitator to kind of know what the relative advantage and disadvantage of different shoulder imaging is. Again, they're going to have a lecture on this as well, so do not feel that as a faculty member you need to cover that in detail. So our physician is reviewing the x-rays, front desk, and they're about to call Mr. Brookstone back about his x-ray and his fracture. In their haste, they have also missed the fact that they pulled up the wrong x-rays. They're about to call the patient back, and then a patient with severe asthma comes in, and it talks briefly about having to stabilize a patient who walks into your clinic who's quite sick. And we do want the students to think about, how do you manage unintended and unexpected interruptions? This is something that is occurring more and more throughout medical care, which is that it's very hard to focus on one task without getting interrupted. Obviously, this has implications for the best way to stay focused on a single task. And students should think about that. Like, how am I going to deal with the common interruptions that I have? And then some of the challenges of trying to task switch from doing paperwork to all of a sudden taking care of a sick patient to going back and doing paperwork, entering things in the EMR. So we present a couple discussion points that could be done here. Again, you can bring up as many of these as you'd like, depending on how many of the students discuss during this. We expect that they probably will, this will be the first time they think about challenges like this. And so these are prompting questions that you can address and discuss with the students, depending on how much time you have. So we now jump back to our clinician here. So this is the end of the day. And the clinician realizes they never returned call from Mr. Brookstone. Another portal message has come in that time, so he's certainly getting worse. The clinician then pulls up his correct x-ray, so now we see here that this is actually the correct x-ray, and now we have a different image and a different shoulder x-ray. So this one looks much more appropriate. It's the correct shoulder. We do not see a fracture, which is more appropriate with this type of, based on the injury that's described. So chance for the students to talk about what's different during the x-ray at this time. And we show the patient's radiograph, and this is the facilitator guide. So the patient's radiograph versus what a shoulder and anterior shoulder dislocation might look like. So the shoulder is not dislocated. This does have some evidence of calcific tendinopathy. Again, this is really just a chance for the students to think about why he might have that. I do not want you to feel that you have to go into detail about that specific finding, but this is potentially a cause for his more chronic kind of ongoing shoulder pain. But really what we would like to focus on the most is what do we do? Mr. Brookstone has now left 3 messages. What are the options for something stronger for pain and for sleep? Does his history of drug abuse that he admitted to during his first visit, does that change your consideration about what you might give him? And then other interventions. So beyond just calling him in a script for a medicine, is there any other interventions that should be considered at this point? And walking through physical therapy options, anti-inflammatory medications, cortisone injections, other possibilities for that. And then again, thinking about this fact that Mr. Brookstone is relying on his YouTube channel and posting to his YouTube channel to continue to make money. And so are there things that he might do or that you might do as a physician to get him back and active sooner than possible? What are the relative benefits and risks? And then we want students to step back a little bit and just think about managing the amount of information and all the tasks that come in as a physician. So one of the challenges, especially in primary care these days, is all of the things that happen during a busy clinic day and then managing all of the follow-up information, filling out forms for insurance, getting multiple portal messages, having lots of questions come in from patients, and then being able to actually finish that and go home and do other things and be engaged with your family, be engaged with your friends, find time for other wellness activities. Students are probably already struggling with some of these challenges as they work through balancing the requirements of medical school, especially during anatomy. So this is a much busier module than the last module was, and they are going to continue to get busier. And so even during this second week, the students should feel a lot of the pressure of having to go to the anatomy lab a lot more. This is a chance to just reflect on what are the habits that they're building into their day-to-day routines now that help them refresh, rejuvenate, because those same challenges exist in medical practice as well. Once you get through medical school, things do not get any easier, and certainly your time gets even more crunched. And so this is just an opportunity for the students to say, wow, as a busy clinician, you're going to have lots of things pulling at your time as well. What are some strategies that you're using now or thinking about now that help you engage a little bit further? So that's the end of part 2. In part 3, they're going to go through the article, and we'll spend a couple minutes highlighting that at the end of this. So Mr. Brookstone returns. He's feeling a little bit better in terms of he doesn't have any more numbness and tingling, but still having quite a bit of pain and feeling pretty depressed just generally about the fact that he hasn't been able to get back to his regular activities. And we do introduce again some ongoing depression and prior attempted suicide when he was a teenager. So again, some mental health things that the student should be thinking about as well, and someone who has already admitted to a history of substance abuse, who is doing some risky behavior. And they should, again, be able to think about that whole more holistic view of a patient as not just a single problem, but an amalgamation of different things that are going on in their lives. So this is a chance, again, for the students to do a more complete history and physical because his shoulder exam was limited before. So we're going to talk through, again, how you might approach a shoulder exam. The students, most of them should have during PCL done this, and so this is a chance for them to kind of talk about some of those exams they learned during PCL. We also ask them to just think through beyond just the musculoskeletal component, what other things might be in a differential diagnosis at this point. So a couple other things the student can think about: referred pain to the shoulder. Referred pain just indicates that several other cardiovascular, gastric issues can sometimes cause referred pain to the shoulder, and that should have been in the initial differential or could have been included there, and so it's a chance for them to think about that broad differential. The patient admits that he's been popping a lot of goody powders. Goody powder is a acetaminophen, aspirin, and caffeine combination. Overuse of acetaminophen certainly can be concerning. Aspirin use can cause GI ulcers and bleeding, and so we might be concerned about the fact that he is now using a pretty excessive amount of over-the-counter medications as well. Talking through this a little bit further, we have a pretty short visit, so some of the pressures of doing a full mental health screening during this limited time and how you might schedule a follow-up visit, make sure he's safe to go home. Talking a little about his voluntary use of a sling and some of the risks of causing adhesive capsulitis, so a frozen shoulder, which often can result after using a sling for longer than you should. We have a kind of final resolution, final musculoskeletal exam, again, that's a little bit more detailed. And at the end, we're asking for some clear advice about whether or not you should get an MRI or a steroid injection. And this is really a chance for the students to kind of at the end say, well, what do we think? Based on what we've learned this week, would we recommend an MRI? Would a shoulder injection be useful? And that's the end of the case there. So this is a pretty involved case. We added a little bit more information on the Friday session purely because we want the students to be bringing in a lot of the information they've learned during the week, during the case. This is a long guide. There's a lot of possibilities of asking questions. As a facilitator, I would encourage you to use your best judgment about where you think those questions should come in and which of those questions maybe get saved for later or maybe don't get asked at all. So you do not feel like you have to cover every single word in this facilitator guide. I've provided a lot of information in here to allow the students to kind of explore down different paths. And if they start going down different paths, we wanted to make sure that you had some background material for this. So I think lots of interesting questions you can ask. It's okay if you don't get through all of the questions. We certainly want the students to get to the end of the case so they can think about kind of what their next steps would be. So let's jump to the article very briefly here. So this is a prospective cohort data from a national longitudinal study of adolescent health and adult health waves. So essentially, this is a survey that was sent out to a whole bunch of young adults, and they specifically pulled out information about the use of legal performance-enhancing substances, and it talks in the article about what those are, and then risks of down-the-line substance abuse and risky behavior. So what we want the students to think about during this article is what a prospective cohort data is, especially one that's based on survey results. This is a lot of how we get information about generally use of things like alcohol and caffeine, about a lot of the studies about nutritional science have to do with sending out surveys. And there's lots of benefits to do that. Obviously, they got information from a lot of young adults. There's a lot of downsides. Obviously, people do not always tell the truth on surveys. And so this is a good chance for the students to think about, okay, well, how much should I believe this information? What are the limitations of sending out these types of surveys? What are the benefits of sending out these types of surveys? Should I be skeptical about what science and what some of the articles when I read in the paper that says that red meat is associated with high risk of every type of cancer is, again, a lot of this is based on doing surveys of asking people to, how much red meat do you eat? Have you been diagnosed with cancer? And so there's some robust information that can be learned from this, but also obviously some downsides. So it's a good chance to talk about that. Thinking about some of the reasons that young adults use legal and illegal performance-enhancing substances. So it goes through this in the article as well. They talk through some of these correlations that they found. Again, correlation does not always mean causation. So this is a correlation between, and they emphasize here that what they found most is that young men who are using these legal performance-enhancing substances tend to have higher rates of the use of risky behavior in terms of alcohol use and then of other use of other controlled substances as well. They didn't find as much of a correlation in females in that respect. This is again a correlation study, so that they can't prove that the use of these substances is causing people to then use more cigarettes and alcohol and illicit substances. They just emphasize a correlation. So it's very hard to prove causation. It's very easy to find correlations. And there might be some reasons why we would find these correlations. There might be some reasons why the people who are responding to these surveys might be biased towards giving you specific correlations as well. So the students can kind of talk through that component as well. And that's the end of the article. That wraps up our week 13 in review. Hopefully this was a little bit helpful kind of thinking through that faculty guide. It is a pretty complex case. There's not a lot of complex medicine involved, but more a lot of just the challenges of day-to-day management of any patient that might roll into your family medicine clinic. Hope this was helpful and look forward to talking to everyone very soon. Take care.